Exams? I have not read, I have not studied. What will happen? Kya hoga mera? How will I deal with it? If your mind also gets clouded with all these questions when exam date arrives, just take a deep breath and relax. Because it's never too late. You can start your preparation right now. Hey everyone, welcome back to Dento'ZEN. Today we are here with a new video on topic Odontogenic Keratocyst to help you prepare well for your exams. In this video, we are going to talk about introduction, terminology, origin, clinical features, radiographic features, histopathology, diagnosis, differential diagnosis, treatment and prognosis of OKC. So before we begin, I want you to quickly subscribe to Dento'ZEN and also hit the bell icon so that you remain notified about new videos. Now the term odontogenic means the one which is arising from tooth forming tissues, and that is the first Viva question. The origin of OKC is from remnants of dental lamina or cell rest of cell. Now different odontogenic cysts can arise from different odontogenic tissues. So to know that, tap on the I button above for the video on odontogenic cyst. Now in this cyst, the epithelial surface produces lot of keratin and the entire lumen gets filled with the keratin. That's why keratocyst. Here is your next question. Why it is named keratocyst? Because cystic epithelium produces so much keratin that fills the lumen. Now because it was thought to be arising from the primordial odontogenic epithelium, the one in the earlier stages of tooth development dental lamina, it is also known as primordial cyst. But this term has fallen into disuse. Why? Because the term primordial cyst was given by Robinson in the year 1945 for all those cysts in which the stellate reticulum degenerated before any mineralized tissue was formed. So in place of hard tissue, in place of tooth, there is a cyst. Whereas the term odontogenic keratocyst was introduced by Philipson in 1956 for all those cysts which produces keratin. So these two are different, and it is justifiable not to use these two terms synonymously, and the term primordial cyst should be avoided. Now there are specific features of OKC which were described by Pindberg and Hansen in 1963. Now there are other cysts like dentigerous cyst, gingival cyst which may produce keratin. Then how do we differentiate OKC from them? It is based its specific histopathology that we do that. Now there is a twist. Stoller in 1967 suggested that OKC is DON, that is, it is developmental odontogenic cyst with neoplastic behavior, tumor-like behavior. To reflect that, WHO in 2005 renamed it as keratocystic odontogenic tumor. That is your next Viva question. What is new terminology for OKC? It is KCOT. But in 2007, WHO renamed it as odontogenic keratocyst because there was not enough evidence to support its neoplastic behavior. Whether it is cyst or tumor, lot of confusion. Now, why it was considered tumor? First, because of its aggressive clinical behavior, it shows lot of destruction and it keeps recurring. You remove it and it will come back. So no doubt it is the cyst with the highest recurrence rate. That is your another Viva question. Second reason, because the epithelial lining showed high mitotic rate, cells were dividing very rapidly. Third, there were associated genetic and chromosomal abnormalities like high expression of mutated tumor suppressor gene P53 gene, which is usually seen in malignant cells. Also raised levels of Ki67 and proliferation cell nuclear antigen, which are markers of proliferation, they were raised. Then very important gene, PAD gene, was also found to be mutated, especially in OKCs which were part of a syndrome. Now another important question here, which is your entrance question, where is this gene located on chromosome 9q22.3? Also, certain molecules like collagenases were found. The enzymes which breaks down the surrounding connective tissue helps it to invade and extend. These are like matrix metalloproteinases 2 and 9. So because of all these reasons, it was considered a tumor. Now we already know its origin is from the remnants of dental lamina. Now there is one more origin, from the basal cells of overlying epithelium of the overlying mucosa. These cells have the proliferative potential to form OKC, and these are called basal cell hamartias. That is another important exam question. Now coming to the clinical features, it has bimodal age presentation, two peaks. Bi means two. First peak is at second and third decade, and second is at fifth decade. Now it was observed that most of the OKCs remain undiagnosed and they are discovered later in age. That's why we see the second peak. Males are affected more than females with ratio of 1.44:1. Now, if we talk about sight, mandible is affected more commonly than maxilla. Very important. And in mandible also, it is the posterior body ramus, third molar region, followed by first and second molar region, and then the anterior mandible. These lesions remain above the inferior alveolar canal. That is important for your entrance. Now, if we talk about maxilla, the most commonly affected site is third molar area, followed by the cuspid region. Now, these OKCs can start in one side, can cross the midline, and can go to other side of the jaws. is that seen? Some studies have reported that, but while others have not seen. So for entrance, you can stick to that the OKCs do not cross the midline. Now, can you see multiple OKCs? Yes, it is seen in association with the syndrome, Golin-Gall syndrome, which is also known as Golin syndrome. And because you can see multiple basal cell carcinomas, malignant skin tumors, it is also known as nevoid basal cell carcinoma syndrome. Because you can also see bifid rib in these patients, so this is also known as bifid rib syndrome or Joss's bifid rib syndrome. All names for the same syndrome. Along with that, you can see skeletal defects, you can see central nervous system involvement, you can see calcifications, pits on the hands and feet, which are known as palmar plantar pits, and typical facial features like frontal bossing of the frontal bone, and ocular hypertelorism, that is increased distance between the eyes or widely spaced eyes. For diagnosis of this syndrome, we have to take family history, we have to take oral and skin examination, x-rays, OPG, and MRI of brain. Now, there is another important term, important syndrome, which seems similar to this, but it's totally different, and that is Golin syndrome. Your examiner can easily confuse you, but this is totally different disease. It is a skin disease. It is known as focal dermal hypoplasia. Dermal structures are less formed, hypoplastic. Now, how do I remember? Golin has more alphabets, and the syndrome with OKC has more features. So that is how you can remember. Now, coming to the clinical presentation, 50% of the patients present with symptoms prior treatment. So these symptoms can be pain, they can have soft tissue swelling, there can be expansion of bone, and paresthesia of lips and teeth when it is close to nerves. Maxillary OKCs tend to be easily infected because they are very close to maxillary sinus. Now, if we talk about the growth pattern of this cyst, that how it grows inside the bones, it has a very unique growth pattern that is known as the intramedullary. That is, the cyst, if starts forming, it grows within the medullary cavities of the bone like this. And because you can see it is growing in anterior-posterior direction, that is your next Viva question. So the direction is anterior-posterior and not lateral. It is not growing in buccolateral direction. So we do not see any buccolateral expansion of the bone. And because of this pattern, it is also known as burrowing expansion because it is invading into the medullary cavities, and that is your important entrance question. Because of this behavior, it is that OKC is an aggressive lesion. Now, talking about the radiographic features, it is a cyst, so it will present as a unilocular radiolucency with well-defined rim or margins. But this borders can be frequently scalloped. Scalloped means you can see arches like this, and that is because of the unequal growth of the cystic epithelium at different sites. Epithelial lining is growing at different rates in different parts of the cyst. So that is why we see scalloped border. That can be your Viva question. Now, we do not see any buccolingual or very little buccolingual expansion, and when it is growing close to the teeth, it comes to lie to the superior border of the bone in between the teeth, and this is called scalloping of the superior border. These arches are formed. This is called the scalloping of the superior border, which is also sometimes referred to as arc-shaped for your entrance exam. Now, this can cause the resorption of the roots, but that is less common, and more common is the displacement of the roots. Now, if it becomes multilocular, that is, there is central cavity and small cavities which represent the satellite cyst, it gives multilocular appearance similar to a tumor which is ameloblastoma. So that is the radiographic differential diagnosis. Now, if these locules compartments are small, it is called as honeycomb appearance, madhumakhi ke chhate jaisa. But if these locules are big in size like bubbles of soap, it is called soap bubble appearance. That can be your Viva question. Now, when it comes close to the roots of a tooth in the periapical region like this, we can confuse it with radicular cyst. And if it comes close to an unerupted tooth, then we can confuse it with dentigerous cyst. So these are the radiographic differential diagnosis. Now, coming to the radiographic features or the types or the varieties. First one is envelopmental, when it is lying, embracing adjacent unerupted tooth, lying very close to it. This is also known as embracing type. That term is important for your entrance exam. Now, second is when it is found in place of a tooth. So in place of a tooth, a cyst has formed, it has replaced. So that is replacemental type. This is not considered anymore. This is outmoded. Now, extraneous type, when it is growing in the ramus of the mandible, away from the tooth bearing regions, in the non-tooth bearing regions, that is your extraneous type. And then we have the collateral type. Collateral means lateral to the roots of the teeth. So when it is seen in between the roots of the teeth, especially in the mandibular premolar region, then it is called collateral type. Now here you can confuse it with lateral periodontal cyst. That can be the radiographic differential diagnosis. Now another type in which the enlarging OKC involves the follicle of unerupted tooth. यहाँ पे एक unerupted tooth पड़ा है, उसकी follicle है और उसको ये enlarging OKC involve कर ले, then what we can see is that a cyst which encloses the crown of the tooth. Crown is lying in the lumen of the cyst and it is attached to the neck of the tooth. But when we see it histopathologically, what we see is that the epithelial lining just near the neck of the tooth is similar to reduced enamel epithelium, whereas the remaining of the epithelial lining is similar to OKC. This radiographic type is called follicular, and that can be your viva question. So follicular type is when enlarging OKC involves the follicle of the unerupted tooth and its epithelium gets fused with the reduced enamel epithelium of the follicle. Now coming to the histopath, we do not receive intact OKC. What we receive is multiple pieces and the epithelial lining is usually folded. So the characteristic histopath findings about the epithelium and the connective tissue of this cyst is the epithelium is keratinized. We see a lot of keratin over its surface and it is regular or uniform thickness. That means the number of layers throughout the epithelium are same. That is, we cannot draw it like this. That is, we cannot show different number of layers in different parts of the lining. So it is a type of stratified squamous epithelium because there are layers. Strata means layers. How many layers are there is next important Bible question. 6 to 10 cell layers. Now sometimes it's said to be 5 to 8 cell layers. So both answers are correct. Now talking about the surface of this epithelium, that is towards the lumen, it is corrugated. It is not smooth. It is irregular. Which is also known as wrinkled or rippled or wavy for your entrance exam. So it's like waves or ripples. So that is the surface of this epithelium, and then there are no retipex. That means epithelial connective tissue interface is flat. There are no projections of epithelium into the connective tissue. Most of the cases, 83% show parakeratin on surface. That means you can see pycnotic nuclei on the surface. But 10% may show orthokeratin and 7% can show both. Now it is said that orthokeratinized one is totally different in its behavior. So it is now considered as orthokeratinized odontogenic cyst. Totally a different entity that we'll discuss later. Now talking about the layers of this epithelium. If we talk about the basal layer of this epithelium, it is made up of columnar cells with their nuclei which is arranged at the same level for all cells, which is called palisading arrangement of nuclei, and the nuclei are away from the basement membrane, that is on the opposite end, which is called reverse polarity of nuclei. So this arrangement of the basal cells of the epithelium of OKC is known as picket fence or tombstone appearance. Very, very important viva question. Tombstone, you might have seen large stones, flat inscribed stones over the graves. Then that is why it is called tombstone. And picket fence, you might have seen the garden fences which are made up of longitudinal structures with horizontal connections, so it resembles that. That's why it's called picket fence. Now here comes another important viva question. Where else you can see tombstone appearance? That is seen in other disease, skin disease, that is pemphigus. That can be your important viva question. Now talking about the layers above the basal cell layers. The layers above the basal cell layers are composed of polyhedral shaped cells. Polyhedral cells which can show intracellular edema, the swelling of their cytoplasm. Now mitotic figures. Mitotic figure is a cell which is in the phase of cell division in which the genetic material will be arranged like this at the two ends. So such type of cells can be seen in the OKC lining, especially in the suprabasal layers, that is above the basal cell layer. We can see these mitotic figures, the cells in the phase of division. Now epithelial dysplasia, that means this epithelium can show dysplastic features, changes in the cells. So if that is observed, it can be indication that it is undergoing malignant transformation. So does that mean the epithelium of OKC has potential for malignant transformation? Yes, it can change into squamous cell carcinoma. To know more about epithelial dysplasia, tap on the I button above for the video on epithelial dysplasia. Now talking about the connective tissue wall. Now connective tissue of OKC is thin fibrous capsule with few cells interspersed with few cells and often rich in mucopolysaccharides. Now there is a very, very important in the connective tissue wall that is known as satellite cyst, or which are also known as daughter cysts. So these cysts resemble the main parent epithelial lining and they have a lumen in the center. So what are these satellite cysts or daughter cysts? Now the first explanation that has been given that when we cut this folded epithelial lining in the cross section, a part end of the fold gets embedded in the wall of the cyst. So that will appear as satellite cyst. So that is first point, that it represents the ends of the folds of the main epithelial lining that get cut in cross section and come to lie in the connective tissue wall. Second is, it can be said that actual epithelium keeps on proliferating and it is pushed into the connective tissue wall. Because of active proliferation of epithelium, it gets pushed into the connective tissue wall, and that we can see as another satellite cyst. Now third is that actual basal budding of the cell of the parent epithelium, मेन लाइनिंग जो epithelium है उसके parent cells basal cell से budding हो सकती है और नीचे wall में वो आ सकते हैं. So that is why maybe they are also called daughter cyst. Fourth is that there may be already presence of some islands, odontogenic epithelial islands in the wall, which starts to divide rapidly. They increase in size, and the central part of these, they degenerate, a cyst cavity is formed. So those can be the explanations for satellite cyst or daughter cyst. Now talking about the other things, there can be epithelial rests in the wall. Then there can be proliferating dental lamina islands can also be seen in the connective tissue wall. Now if we talk about the epithelial connective tissue interface, it is flat, and because of which it is a weak junction, and that is why epithelium gets easily stripped away from connective tissue. Connective tissue से अलग हो जाता है, and you can see a space between the epithelium and the connective tissue. That can be an important point. Now coming to the inflammation. If there is inflammation, if it is mild, you can see in chronic inflammatory cells in the connective tissue wall like lymphocytes and monocytes. And if it is intense, then epithelium will lose its keratin. It will become thicker, cell growth will take place, and there will be development of red apex, and even the ulcerations on the surface of epithelium, it may break down. Apart from that, you can also see changes in the epithelial lining. It can become to mucus cells, so it can show mucus metaplasia. There may be presence of hyaline bodies like this, or there may be presence of cholesterol clefts. Now coming to the contents of cystic lumen. Whenever we suspect that it is a cystic lesion, we do a procedure which is known as FNAC, fine needle aspiration cytology, whereby we put a needle inside the lumen of the cystic cavity and we aspirate its contents. So in OKC, it may be empty, then we will not get anything. But if it has fluid, it may be straw colored fluid, or it may be thicker white cheesy material. And what is that thicker white cheesy material? It is keratin. That can be your Viva question. Toller studied the protein level in the fluid, and he said that less than 3.5 gram per 100 ml is seen in OKC, because OKC is a keratinizing cyst, so its lining is impervious. It will not allow the proteins to come inside, much of the proteins. Whereas compared to other cysts like Dento'ZEN cyst and radicular cyst, in which lining is non-keratinized, so they can allow some smaller proteins to get transmitted into the lumen. So that is your important interest question. If it is more than 5, it is OKC. If it is less than 5, it can be Dento'ZEN cyst or radicular cyst. Then if we take out these fluid contents and spread on the slide and stain them, we can see keratinized cells, keratinized squames can be observed. Also, we can see cholesterol and hyaline bodies. Now coming to diagnosis. Diagnosis is based on correlation of clinical features, radiographic features, and histopathological features. Final diagnosis is given on histopathology. We have already seen differential diagnosis, ameloblastoma, Dento'ZEN cyst, radicular cyst, lateral periodontal cyst, and they are differentiated based on histopath. OKC has specific histopath features which helps us to diagnose it. Now, different entity OOC. It is different clinico-pathologically. Clinical differences are that it has low recurrence rate. It is not seen in patients with the syndrome. In those patients, OKC is seen. Then it is mostly found in the mandibular third molar region, and usually solitary single cyst is seen, and it is less aggressive behavior. Pathologically, histopathologically, this epithelium has thin lining and it is orthokeratotic. That is, we do not see nuclei in the keratin, and we can see prominent stratum granulosum layer with prominent keratohyaline granules. And the basal cell layer is different from that of OKC. It is made up of flattened or cuboidal cells. So Now coming to the treatment. Treatment of OKC is very challenging because it has thin friable epithelial lining. It can invade to deeper structures. So that all these things can complicate the treatment. But definitely we have to do surgical treatment, and that depends upon various factors like age, cyst site and size. When the cyst size is small, we can remove it completely. And if the cyst size is big, we can do marsupialization. So if it is small, we do enucleation. If it is big, we do marsupialization, which is known as deroofing. That is, we remove the complete roof of the cyst. But that is not enough for somebody like OKC. As OKC is aggressive, we have to do aggressive treatment. So along with that, we can do curettage. That is the bony cavity which remains behind after the removal of the cyst. We have to curate the remaining tissues with curettes. We have to do peripheral ostectomy, bone removal. Margins of bone are removed using electrical cautery, or we can use carnoise solution which contains chloroform. It is applied over the bony cavity to make sure that nothing is left behind and there is no recurrence. But when cyst is very large, huge, sometimes we have to cut down the mandible in a way where the bone continuity is maintained. So that is called peripheral resection. But when we cannot save that bone also, we have to completely remove one part of that, one block of that mandible. That is called en bloc resection. So in that case, later that defect which is produced can be filled with grafts. So no enucleation can be done with open packing, when we keep it open and give a pack made up of iodoform and antibiotics, or we can do it with primary closure. So those can be the different treatment strategies for OKC. Now it has high recurrence rate, 30%, that is your viva question, and it has chances of neoplastic transformation into squamous cell carcinoma. Now recurrences are more commonly seen in cases which are in the third molar ramus region, in the cases which have multilocular appearance on radiograph, in cases which have scalloped margins on radiograph, in cases which have got infected, and in the cases with nevoid basal cell carcinoma syndrome. So in all these cases, chances of recurrence are high. Now why this recurrence is so much? First important reason, presence of satellite cysts. They can be retained behind when we remove, and they can give rise to new cysts. Second is thin and friable epithelial lining which breaks down while removing, and it can be left behind, from which new cysts can arise. Then intrinsic growth potential of epithelial lining. It keeps on dividing and can invade the structures, and its margins remain beyond identification on radiographs or surgery. हमें margins पता ही नहीं चलते हैं, we cannot identify, and incomplete removal can happen. Also when it is close to vital structures, like it is close to nerves, we try to save them, and in that attempt we can leave behind some of the cystic lining, and from which the cyst can recover. Then there are other sources of epithelium from which it can arise again, like basal cell layer of the oral epithelium. So because of all these reasons, it has high recurrence. So what should we do? We should do a long-term follow-up of such cases, that we have to do periodic monitoring, we have to take x-rays, and we have to check for recurrence. So that is all for OKC. Let's quickly revise. OKC has its origin from dental lamina remnants or basal cell hamartias. It is called keratocyst because there is a lot of keratin production in the cyst. Now, the old term for this was primordial cyst. New term for this was keratocystic odontogenic tumor, which was given by WHO in 2005. Now it has renamed back to OKC by WHO in 2017. Now the gene mutation which is seen is your patch gene mutation located on chromosome 9q22.3. Now if we talk about the clinical features, age, bimodal presentation, two peaks are there, males are affected more than females, mandible is affected more than maxilla, and that too in the third molar ramus body region. Syndrome which is seen with this is known as Golin-Gall syndrome, or also known as nevoid basal cell carcinoma syndrome. Then if we talk about the growth pattern, very important, it is antero-posterior direction and also known as burrowing type of expansion. Then if we talk about the radiographic features, it is mostly unilocular radiolucency, but when it is multilocular, it can resemble ameloblastoma. Other radiographic differential diagnosis can be dentigerous cyst, lateral periodontal cyst, and radicular cyst. Then we talked about the radiographic types. It can be envelopmental, replacemental, collateral, extraneous, and the new one, that is follicular. Now if we talk about the histopath, it has characteristic histopath lining made up of parakeratinized stratified squamous epithelium, 6 to 10 cell layer thick, of uniform thickness, no retipegs. Very important, and its surface is corrugated or rippled or wrinkled or wavy. Now if we talk about the connective tissue wall, we see an important finding, that is presence of satellite cyst. Now, there is a variant of this OKC that is known as OOC, orthokeratinized odontogenic cyst. Its treatment include enucleation with open packing, enucleation with primary closure, marsupialization, then ostectomy, curettage, carnoise solution, and resection with grafts. Prognosis is it has high recurrence rate, high cyst with the highest recurrence rate, so because of which we need to do regular follow up. So that is all for OKC. If you still have any doubts for OKC, please do let me know in the comment section below. Keep reading, keep following Dento'ZEN. See you in the next video. Till then, take care and good luck for your exams. Bye bye.